Welcome. This is the Psychosis Psychoeducation workshops. And so we'll be presenting a two-part kind of series today, Psychosis 101 and How to Stay Well. And this is presented by our EPI-CAL Training and Technical Assistance team. I am Dr. Sabrina Ereshefsky. I am a licensed clinical psychologist at UC Davis, and I'm the assessment training director at our Psych-EDAPT and EDAPT early psychosis programs. And I also have my co-presenter today here, Dr. Dan Shapiro. I'll let him quickly introduce himself.
Hi, I'm Dr. Dan Shapiro. I'm an assistant professor here in the UC Davis Department of Psychiatry. I'm also the director of operations for our early psychosis programs here at UC Davis. Welcome.
We're very excited to present this series. Just a quick reminder that we typically go through at the start of all of our TTA presentations, that this is just one of our efforts to try to get out some of the good work we're doing and try to increase evidence-based services that we're providing across the state. The EPI-CAL TTA is a collaboration between UC San Francisco, UC Davis, and Stanford. And so we're really happy to be presenting these different activities for you. A couple of just quick prerequisites, really, they're that you're an active member of a coordinated specialty care program, and that maybe you've had a little bit of psychoeducation about early psychosis. And so we'll be going into kind of what these different presentations will look like. So we'll kind of start off with how do you present these, and then what does the actual presentation look like. Just want to make you all aware that we have some resources available for you in the link tree, and that is also one of the links that's in the chat box. That is the same place that'll bring you to all the different resources for this training and the Eventbrite registration. So, all right, yes. And if you haven't yet, please do the Eventbrite registration. One last plug. All right. So a couple of learning objectives across the two different workshops that you'll learn how to describe the core psychosis symptoms. You'll describe the vulnerability stress model of how psychosis and other symptoms develop. You'll talk about different types of evidence-based treatments for psychosis and explain, in our part 2, we'll explain the 4 components of a wellness plan and learn how to lead participants through developing their own wellness plans. Again, our kind of overview is we'll start off with our Psychosis 101 workshop, which is actually a prerequisite for our part 2 series, which is our How to Stay Well workshop. And we'll have time for Q&A after each session.
We have kind of 2 goals here today. One is to present this information. The other one is sort of to model how you might present this information. So the way we're presenting may be a little bit different than the way you do it. I think we would probably encourage you to have a more fluid format where people are asking questions in the midst of slides. When these questions come up, it's a nice way to generate discussion amongst your families, to kind of generate some interaction between them too, and kind of build some bonds. But since we're presenting that the information in this format, we're going to sort of power through and hold on for questions at the end of each section.
Great. Thank you, Dr. Shapiro. And so, right, so I'm going to start off with the Psychosis 101 workshop, kind of how to set it up. And I'll talk through a little bit of some of those components of how to make it a little bit more interactive, and you'll see us model that. So just first off, who do you invite to these workshops? You know, all clients at your clinic and anyone involved in their care or their key supports. And this can include even siblings, as long as they're old enough to meaningfully participate. The Psychosis 101 workshop is a really great place to start for any new clients or families, or even clients and families who have not participated before, or maybe even weren't ready to participate. Like I said, there's really no prerequisite. So anyone can attend also as many times they would like. Oftentimes we find that repetition is a really important part of the learning phases of treatment. So, you know, this information may be presented in this group workshop format, but then followed up in an individual session with the client and family so that it's really individualized and personalized for them. It's ideal to have these in person, but we, over the past couple of years, have modified this to be in a virtual space. If feasible, though, if you're in person, providing dinner or light refreshments, though we know that that is pending money. Again, build some of that rapport at the very beginning. We do like to do little icebreakers, and that's just to get to know the speakers, the participant, and consider how you're going to handle questions. So do you want to have people write down their questions at the beginning and turn them in on index cards if you're in person, or write them in the chat box onto their questions, and when they come up, you can ask them. And with that, provide them handouts or slides so that they can follow along. Oftentimes people are visual, auditory learners, and also experiential learners. So you want to try to model some of that too. You want to think about how to make this interactive, like I said. Ask open-ended questions and elicit responses from the crowd. Talk about how the information applies to their experience and integrate their responses into the presentation. Typically, we would say that these workshops are like an hour and a half, a little time for people to get adjusted at the beginning, get food if you're in person, but we will be kind of moving forward, and I'll be like demonstrating where you might ask a question and then kind of just filling in some possible responses that you might hear. And then one last thought plug about the materials. So we have provided a set of slides, PowerPoint slides that have like presenter notes in them. So one set for the Psychosis 101 workshop, and then one set for the wellness workshop. So they'd be ready for you to edit, add your own kind of notes in the presenter section, however you might want to personalize it. Anything you would like to add, Dr. Shapiro?
In our clinics, we require that all families attend at least once, but there is probably some clinical judgment by you and your team about when the right time is. And I liked, Dr. Ereshefsky's point that sometimes people come more than once, but you may want to think about how to require, right, all of your families to come. This is important information, often useful as they start their journey in your clinic.
Thank you. Great points. Psychosis 101, understanding psychosis. I want you to be thinking about what kinds of questions you have about psychosis. So this is just a filler slide for an icebreaker that you can use and fill out as appropriate. So again, we're not going to model this here today, but just use this as a filler for your own clinic. Okay. The overview for today's work, we're going to talk about what is psychosis? What are the symptoms? What is this diagnosis? What do these symptoms look like over time? Also, what causes psychosis? We'll go through the vulnerability stress model. We will then also talk about how to treat psychosis. What is early intervention? What are protective factors? And what's all this about evidence-based treatment? Okay, so first, what is psychosis? Okay, so today we're gonna talk a little bit about these different categories of symptoms. So when we say psychotic symptoms, what do we mean? We're talking about these positive symptoms, negative symptoms, and cognitive symptoms. And so we'll dive a little bit deeper into each of these categories. Okay, so what are positive symptoms? Might elicit some responses here from the group to start off with. But then, positive symptoms are generally exaggerations or things that are added to the normal human experience. So think like thoughts or sensory experiences that aren't tied to reality, are held with conviction that do not change even when faced with proof they are false. And you can sometimes think of these as your mind playing tricks on you. Importantly, these experiences really negatively impact your everyday functioning. And then the three types of positive symptoms that we'll go through, some that you might have heard of, hallucinations. This can impact any of your sensory systems. So hearing, seeing, smelling, tasting, or feeling things that are not there. And the most common type of hallucination is hearing voices. Next up, we have delusions or unusual beliefs or fixed false beliefs or thoughts. And this can include paranoia or extreme suspiciousness, delusions of reference or things in someone's environment that's having a particular or unusual signal. So some people may explain this like feeling like a song where the radio has a message that's directed just to you. Grandiosity is another area, feeling like you have inflated special gifts or talents or power, maybe thinking you're particularly famous or chosen by God for a special role. And particularly here, that does not fit within the typical cultural belief set. Maybe also feeling like your thoughts are heard by others. You can read others' minds or you can predict the future. So just a couple of examples of different delusions. And then thought disorder. This can include things like disorganized communication. Others have a difficult time maybe understanding what you're saying because you may lose your train of thought, go off track easily, or the words you're trying to communicate just aren't really coming out. And so depending on if you have a diagnosis of full threshold psychosis, or if you were told that maybe you just have risk for psychosis, which is a little bit different that we'll talk about in a little bit, you might experience these positive symptoms more or less intensely or frequently, or hold on to them more strongly. And they may be accompanied with more or less distress or impact on your day-to-day life. Okay. Next up, what are negative symptoms? So again, eliciting some ideas from the crowd. What does this mean? Okay. So whereas positive symptoms are exaggerations of the normal human experience, negative symptoms involve the loss or withdrawal of qualities that make us emotionally connected and motivated human beings. So this can include anhedonia, a loss of interest or pleasure in activities. For example, this might look like spending more time alone because you don't get enjoyment out of your social interactions or your previously preferred hobbies. Avolition is this lack of motivation for goal-directed behavior. It's not laziness, it's more about having a harder time getting normal activities done or losing motivation more quickly. You might notice this if a loved one provides lots of prompts for you while trying to do these activities. So like working on chores, completing daily hygiene routine, or working on school or work activities. Flat affect is another area. This looks like reduced expression of emotion through your face, your body, and your voice. So this can appear that you're unemotional or lacking modulation or inflection in your voice or gestures, maybe lacking a little spontaneity and initiative in conversations. And then last up, poverty of speech, just one other area is reduced verbal kind of output, speaking less often. Maybe someone answers things with one-word answers. They don't really elaborate on the responses. And this can be something related to motivation. This could be something, maybe someone's preoccupied by other symptoms, or there might be many other reasons that this is happening. Okay. The last category to quickly go through is cognitive symptoms, which you can think of as impairments in how your brain works and processes information. And this includes difficulties with attention, sustaining focus, switching concentration between multiple things, maybe how you learn and retain new information, whether it's presented visually or verbally or auditorily, might impact different types of memory. So maybe you have difficulty holding things in your mind or losing that information right away. This is called working memory. Or you might have difficulty recalling information after a longer period of time has gone by. And then also problem solving and reasoning. And this can include defining what a problem is, generating solutions, examining those pros and cons, and then implementing and evaluating how things go. And so impulsivity can sometimes get in the way of some of these things. Many of these areas are impacted through the prefrontal area of the brain. So if you want to think this area right here, and often you can think of this as like the orchestra conductor of your brain, which tells other areas how to work. And so it's a really important area that is very deeply involved in psychosis. And we'll get a little bit more into some of those details a little bit later when we talk about biological vulnerability for psychosis. Okay, so after going through those symptoms, it's important to remember that symptoms are common in our general population. So 1 in 4 individuals on psychosis screening questions in the National Comorbidity Survey say that they have psychosis symptoms. 1 in 6 say that they have these symptoms even without a diagnosis. And then 1 in 5 who go to treatment at primary care centers report 1 or more psychotic symptoms, and this is one of the most commonly auditory hallucinations. And so psychotic symptoms are quite common, and the symptoms range from more typical experiences to psychiatric symptoms that impair function. And so you can see it's a really large continuum, and that's kind of what we're going to talk about next. So I'm going to hand it over to Dr. Shapiro to chime in.
Yeah, and a nice segue, I think, for us in doing psychoeducation, it's important to remember that education itself is a really powerful intervention, one of our powerful interventions as providers here. And so there are some kind of important or key messages that we hope people take away from this presentation. This concept of a continuum is one of them. Education, I think, helps people build accurate knowledge, right? We're trying to combat stigma and misinformation. But also it's really important to kind of normalize, and normalizing, we hope, remove some of the distress that people have when they experience symptoms, the expectation that distress leads to more symptoms, and maybe unhelpful patterns. I'm sharing this with you as presenters. But I think it's useful to say when you get to this part that we really hope this idea of a psychosis spectrum is one thing that our families take away, one key thing that our families take away. One key concept we hope you walk away with today is this notion that psychosis exists on a spectrum, and all of us, you and me included, kind of exist or fluctuate somewhere along this spectrum. I would entertain you, and you can entertain your learners, to think about what might differentiate a sort of normal end of the psychosis spectrum from what we might see as more problematic end of the spectrum. So take a moment to think for yourself, right? What differentiates something that we would consider normal in the psychosis spectrum from something that seems more problematic? And as we work through this spectrum, that's kind of the route we're taking, from what is common, as Dr. Ereshefsky was saying, quite common, to what might bring somebody to our clinic. So on the normal end of the spectrum, these are things that occur perhaps without a lot of distress, that are infrequent or rare, and that don't really have a big impact. They don't change your behavior. They don't impact your life or get in the way. So, some great examples are raise your hand or mentally raise your hand. If you've ever heard your cell phone ring and in fact it didn't ring, or if you're a parent, if you've ever heard your children call your name and they're not in the house, or they're sleeping, or there's no way they could have heard you, right? Or you wonder if your coworkers or your friends are thinking bad things about you, or purposely trying to exclude you from their plans. These are really normal. We can suggest that these are sort of on the normal end of this psychosis spectrum. So taking an example, we also, for many cases, see that people don't wake up one day with full threshold psychotic symptoms. For many people, there is a sort of gradual lead up over time, with things starting on the normal end of the spectrum and occurring more frequently, starting to become more confusing and then more distressing. There are certainly cases where these pop up in acute phases right away, but this is more prototypical. So to think about an example, this is an example actually from one of our colleagues. Imagine seeing a ghost. This happened to this colleague. The ghost appeared one time at night while they were trying to sleep. They thought it was a loved one who had recently passed. This was comforting to the person. There wasn't a whole lot of impact, although as she tells the story, she talked to her mother about this and actually learned that her mother had similar beliefs and had some similar experiences. So this was really consistent with what was normal for her culture, normal in their family. This was a common experience, right? So no distress, not a lot of impact on functioning. This was actually comforting more than it was scary. So moving along, sort of along this spectrum, we often see these things start to increase. So imagine this has happened to you, and now it's happened again, or maybe it starts to even happen weekly. Once in a while, things you're pretty easily able to pass off, but once they start to recur, right now your mind starts to try to put the pieces together and wonder what's happening. So as we move into what we call this attenuated spectrum, part of the spectrum, what we think of as clinical high risk or sort of ultra high risk part of the spectrum, we're now starting to see recurrence. It's bothersome. Why is this happening? There seems to be some meaning now because it's happening more and more, but I can kind of reality test and I recognize this isn't really happening. And actually, maybe that's even where some of the distress is coming from. Like, I know this isn't possible, and yet it keeps happening. Why is this happening to me? Typically early on, it doesn't affect your behavior so much. You kind of think about it. You might check in with your head a little bit, but you can kind of keep going on your way. So using our example, this ghost has now started to come back a few times a month. This colleague wasn't really sure why. This was not so consistent with what her mom was saying, starting to wonder if maybe it's real, but that still kind of seems out of bounds. It's affecting sleep. So we're starting to see some distress pop up. Moving us along a little bit here, further through this attenuated part of the spectrum. Now it's occurring weekly, right? And again, as you have these sort of intrusive experiences, it's human nature to try to figure out what's going on. So maybe now the person is starting to put together some theories. It's starting to feel more distressing. The fact that it's recurring makes you wonder, okay, is this real? Could this really be happening? It doesn't match my beliefs, but maybe it's there. And now maybe it's starting to impact your behavior. You're looking for signs. You're trying to catch the ghost. Maybe you stay up late to try to look for signs of it. And using our example, maybe now this is a few times a week and it's not so comforting anymore, right? So the theory could be, maybe this is my dead relative trying to communicate with me. Maybe there's something special about me. I'm able to see this because there's something unique or special. I have a gift. And again, I think impacting your behavior, and you can see how this would cycle too. Less sleep, more preoccupation is going to potentially lead to more distress and more symptoms. Once we reach a point of psychosis threshold, for those of you that have done some of your SIPS training, we see that threshold as occurring when conviction hits 100%. I am now sure this is happening. I'm sure there is a ghost in the room. It's scary. I can't really be shaken out of this conviction. That's the point at which we would say this threshold is met, and we've sort of moved further along this spectrum. So using our example, perhaps now this person is starting to think, has developed the belief that the dead is communicating with her. It's really scary. This is happening while she's trying to sleep in her safe space. She might be communicating back with the ghost. And this is starting to impact work and school. It's really distracting. People can fluctuate some along this threshold, which makes some of our assessment questions a little more complicated at times. The hope is that this spectrum idea helps people feel not so different, right? And really communicates that what you do and the way you make sense is what differentiates the quote normal from the abnormal. We're trying to kind of divest people from this idea that they're losing it, right? Or some of the stigma beliefs like, right, this is illness, I'm broken, I'm crazy, right? This spectrum really helps people to feel some kinship with others. Symptoms are common. Psychosis symptoms are common. Disorders, psychotic disorders, what we would label with the DSM, for example, are less common. And it's really these points of distress and impact that differentiate a disorder from a non-disorder. So psychotic disorders, we say are found in about 1 in 50 people, about 2% at any given time. And our average age of onset is teens and 20s. So that's for this full threshold. The spectrum often for people in a prototypical case, we're seeing pop up a couple of months, even to a couple of years before people meet that threshold. Looking a little bit over. So a diagnosis, what makes this different, right? Again, we're thinking about impact, distress. A diagnosis itself is a label. It helps us communicate with other health professionals so that they might understand the terminology we're using and what somebody's experiencing. It's sort of like a syndrome. Think about it as a syndrome. It's a set of symptoms that co-occur in certain ways. And ultimately, the reason this is useful is because different syndromes lead to different treatments that might have more or less likelihood of being successful. Right? We try to do research that matches the treatments to the symptoms. These do change. So this is a really nice kind of demonstration of a prototypical course of psychosis. Really key point for you as assessors is that when we see people walk through our doors, we are getting a tiny little sliver of this overall picture, right? You are getting a small window in what ultimately winds up being the life course of symptoms, right, or their experiences. And so we're doing our best to match a label and a diagnosis to this whole life course based only on one small bit of data, right? So diagnoses change, experiences change for young people. And actually, we find that for a number of folks in that clinical high-risk phase, that symptoms even remit on their own without treatment or with good identification. Okay. So this is another key point that we hope people will take away from the workshop. We've identified at this point some types of symptoms. We sort of distinguished, right, what positive and negative look like. We have talked a little bit about this spectrum idea. For you, trying to fit the right label, think about a prototype matching kind of model. Because we have this tiny little sliver at the beginning, right, we are doing some prediction based on what you have in front of you. So the idea of a prototype is the more what you have in your office in front of you looks like a prototypical case of psychosis, maybe the more your confidence jumps that that is the right label for this picture, right? The less what you have in front of you, the less it looks like the prototype, or the more other stuff is going on, the more unclear this is, right? The more muddy or unsure we are. So the prototype for us is seeing these negative symptoms. So these are in red. Looking at this figure, we have time on the horizontal axis going left to right. We are increasing over time. Yes, the vertical axis here, think about severity of symptoms. So as you move from left to right, we're going forward in time. As you go from bottom to top, we're talking about symptoms that are getting worse. So looking at red, negative symptoms in red, we typically see negative symptoms pop up first. The further away these symptoms are from the onset of psychosis, typically, the less easy it is to identify them as psychosis, if that makes sense, right? So think about a low-level negative symptoms. difficulty in school, difficulty concentrating, poor motivation, right? Hard time getting started on things. I think all of us could think back to our adolescence and probably identify a couple of those. Right? These are the further away you get from the onset of psychosis, the more difficult it is to distinguish these early symptoms from what we are calling psychosis. So yes, in this prototype, typically we see the negative symptoms pop up first, followed by gradually increasing positive symptoms. So these are the blue line here. It is not always linear, right? There's some coming and going depending on what's going on in your life or your stressors. And then once we hit the acute phase, that is marked by this horizontal line, sorry, this vertical line here, that point of conviction, we label this as psychosis. So for us intervening, we know that the earlier we intervene, the better people's long-term outcomes are. So our goal is to try to jump in as soon as possible. There is another period in here. It takes a while usually for people to identify psychosis. Any guesses? Let's go to audience participation here. You can ask your families, but any guesses in this country what the average length of time is between when people develop a psychosis, a threshold psychosis symptom, and they initiate treatment? It's very interesting to see the range that families guess. Yes, actually in this country, it's about a year and a half. I mean, imagine having these symptoms of psychosis for a year and a half without any support or treatment. I mean, that is a long time to sit with these scary things. So the other thing I think to demonstrate in this figure, right, beyond that, the goal of early intervention is that there is often fluctuation in symptoms over time, but also we are much better in our treatments at addressing positive symptoms than negative symptoms. We often see with treatment, or even for some people without treatment, that positive symptoms do start to tail off a little bit, while the negative symptoms often stick around. And actually, unfortunately, in our treatments also are not as great at addressing negative symptoms. Probably everybody on this call can relate to that fact. Great. Just for you to know, another key concept, right? Considering this idea of spectrum normalizing is the concept of the vulnerability stress model. This is a good place too to pause and get some questions like we just did from your audience. The idea here is that our biological contributants, the heritable things that contribute to psychosis, interact with environmental stressors. And there are a lot on both sides to lead to really anything. This is the same model we have for all illnesses, physical illnesses too. If any of you have physical injuries, right, or health conditions, you probably relate that in moments of stress, physical stress, overuse, those conditions are much more likely to pop up or flare up. Or the things in your family that run in your family may have popped up for you for the first time during a period of stress. The same goes here with psychosis. So another graph, different things on the different axes here. So this time, our horizontal axis is this hypothetical concept of biological vulnerability. So moving from left to right, we're imagining someone with a low level of biological vulnerability, moving along the spectrum towards the right, considering high level. And on the vertical axis, imagine this as stress. And stress is a broad concept here. We mean psychological stress, mental stress. Sometimes this is physiological stress. Imagine not sleeping for a long time. And this red line, kind of going along the top, this is the presence of symptoms. Again, this really applies to anything. But thinking about psychosis, what we're saying here is that somebody with a lower level of biological vulnerability might need a higher level of stress to hit that red threshold. So for any of us, if we were to go a week without sleeping, we would probably develop symptoms of psychosis. Extreme psychological stress. What are other good examples of conditions that might yield psychosis due to stress. Any thoughts, Dr. Ereshefsky? Any other good examples to share with families?
Substance use is a stressor on the system. So that's
Yeah, good one.
repeated. We
Good,
did
good, good.
Yeah, it can be a stressor on the system and kind of bring about some type of biological vulnerability.
Great example. Great example. Yeah. Delirium, right? There's like some kind of stress on the body. Great example, right? The converse, I think, is an important concept for our clients too, that if you have a higher level of this heritable or biological vulnerability, it takes less stress for you to hit that threshold. So for our folks that we know have some family history or have experienced symptoms before, that's an indication that they have a higher biological vulnerability. They may need to be more careful than their friends about these biological stressors. This is one of our message for things like cannabis too, right? You have a higher vulnerability, you may be impacted differently. But this really does normalize, again, this helps people kind of plan their response and remove this like illness model, this either or model. You're either there's something wrong with you or you're normal, which is really counterproductive for us. So biological vulnerability comes from a number of places. I think clients and families like to ask questions about this. I will say that it is not that important, I think, as you give outreach talks or psychoed talks to hone in on specifics. We do know of some genes that are involved in vulnerability. However, unfortunately, we hoped there would be a simple genetic picture, and it's actually really complicated. There are hundreds, maybe even thousands of genes, and they interact. So there's not a psychosis gene. We know about some areas of the brain that seem to be involved in psychosis that are either overactive or a little less active or talk to each other in different ways for those who experience psychosis. However, there's not a signature. We can't do a scan and find that signature by looking at pictures of your brain. So these are looking across large numbers of people. There's lots of interesting stuff here that we could say for other days about where we're finding these genes. One interesting thing here is that there are some traits that can be passed on through vulnerability genes for people who don't hit that red line. So you may see some like relatives of those with psychosis who have some similar experiences, maybe some lower level psychosis spectrum symptoms, maybe some of those symptoms in isolation without a diagnosis. So worth noting, right? Some of these traits might run in families. We touched, you probably can guess the key environmental stressors here. Some of these things have to do with development, physiological development, things that occur prenatally or during delivery. Perhaps the most tightly linked is trauma. And we think about trauma broadly defined. So like having sort of adverse and difficult environments, actual traumatic events, trauma disorders, experiences of trauma. These are environmental stressors that are sort of disruptive to our brains that can move us along that threshold. And then also daily stressors actually are important here too. So family stress, social stress, the piling up of these things is something we may want to look for. Particular stress in school or in social environments. These are adolescents often. And yeah, thanks for the suggestion of substance abuse. That's pretty key. I would say this is a key takeaway. These days, marijuana is pretty ubiquitous among young people. Many of our states, California included, have legal marijuana for recreational use. It is everywhere for young people. So I think we want to be clear that marijuana, even more, cannabis more than some other substances, is linked with psychosis. It moves people along in that graph, right? It's sort of, if you have a biological vulnerability, you are more sensitive to the impact of marijuana. And this is reflected in some very very direct research, actually. We have longitudinal research now linking regular marijuana use earlier in life to incidence of psychosis later. Using marijuana, this was daily, this study, daily or regularly, before age 15 made people 4 times more likely to develop psychosis as an adult. It also seems linked to the THC concentration. So these days, cannabis is much more potent than it used to be. And there are lots of products there on the market that are concentrated THC. So using high potency cannabis makes you 3 times more likely. We'll leave it at that. I think the evidence here is very clear and actually pretty alarming.
Thank you, Dr. Shapiro. So now that we know what psychosis is and what causes psychosis, let's dive a little bit into the question that many of you are probably anxious to hear about, which is how do we treat psychosis? And so 3 key points that we'll go over is the importance of early intervention, boosting protective factors, and the use of evidence-based treatments. So the great thing is you are all part of an early psychosis program, speaking to you all, which means you're here in the early stages of illness. And this is great because research from the past 2 decades really supports the importance of early intervention. But why? It's less invasive at this point in the illness trajectory. Behavioral interventions are sometimes sufficient. And if medications are necessary, you can start off with lower doses and those can be effective. It can be more effective. In general, this early treatment, you might be able to move towards recovery faster. You might have more hope. There's more capacity for change. It also can lead to better outcomes. So we talked about that DUP, that duration of untreated psychosis, that 1.5 years kind of time frame. And so the longer that goes on, that's associated with more challenging recovery. And so the benefits of early intervention, can ameliorate some of that impact. Yeah, so additional areas of benefit, there's sometimes less treatment resistance and there's lower risk of relapse at this point, reduced disruptions to work or school attendance, retention of social skills and support, sometimes decreased need for hospitalization, reduced family disruption and distress. And so, yeah, overall, you can see early intervention leads to reduced risk of unemployment, homelessness, victimization, and social isolation for people with psychosis compared to those without a psychosis diagnosis. Okay. We don't always know why some people get better, but we know some of the things that are protective factors that can bolster this recovery. And we'll go a little bit more into the concept of recovery in our next workshop. And so things that can bolster recovery include treating mood, anxiety alongside the psychosis symptoms. So some individuals only have psychosis symptoms when they're depressed or when they're experiencing mania, for instance, or they have more anxiety or more mood symptoms when they have active psychosis symptoms. So treating depression and anxiety can have this kind of double bang for your buck effect by also helping to treat the psychosis symptoms. There are also very specific strategies to learn during therapy to target psychosis-specific symptoms like hallucinations and delusions. So treating symptoms is a very important concept. We also know that maintaining physical health can be protective. As we talked about before, a major stressor on your physiological system is little sleep, but also too much sleep can be impacting. We also already talked about using substances can exacerbate or worsen psychosis symptoms. So, best practices can be keeping a structured sleep schedule, structured eating schedule and exercise, and limiting or eliminating substances. We did talk about the concept of stress, but it's impossible to eliminate all stressful experiences in your life. But rather the goal should be to reduce any unnecessary stressors and learn strategies to cope more effectively with life stressors. So like adapting educational, occupational, and family responsibilities by adding additional supports or working within someone's strengths. Additional areas that to consider are identifying effective coping skills and practicing them. This is even practicing skills even when symptoms are not present. So when you're practicing these skills, you can more effectively pull them out of your toolkit and use them when you really need them. Strengthening family support and incorporating family or support persons into someone's treatment plan can also be a really effective tool. Support persons can help build more understanding and empathy towards what their loved one is going through. So like we're doing today at this workshop, it can also be useful to support individuals around problem solving, around the best ways to support individuals. And then finally, a new diagnosis can be isolating. So it's important to increase social support, not limit it at this point. This can come in many flavors depending on what's important to you. So extending the support outside of your immediate network can help spread to different types of support. So really kind of using your whole network for different purposes maybe. Okay. So the interventions we use in coordinated specialty care model, which is the type of model our clinic has, are evidence-based. And so some specific examples of interventions may be biological. So these could be medication. We talked about early intervention. You can go with this approach called start low and go slow. And so the goal is to be on the least amount of medication that can give the most effectiveness. Also, kind of a biological intervention is substance use management. We take a harm reduction approach in our treatment. So working with people who are motivated to cut down on substances, knowing it can take some time to get to abstinence. However, as we've learned, substances can interact with symptoms and worsen them. So providing a lot of education on the effects is also important. And in some clinics, they offer some types of groups that can help to work with individuals. So substance management groups or kind of risk reduction groups can be a helpful tool here. The psychological or cognitive kind of frame, we use an approach called cognitive behavior therapy, and we provide this in individual and group therapy spaces. This approach helps individuals connect their thoughts, their feelings, their behaviors, and their body sensations, and work to disrupt these unhelpful cycles. There's also a specific approach that integrates these CBT concepts with treatment of individuals with psychosis, so called CBT-P, so CBT for psychosis. There's also some effective tools that are evidence-based called cognitive remediation. These are like brain games that can strengthen some of those cognitive impacts that we talked about earlier. Skills training, this is a really effective tool. This can take place in individual settings or group settings, but especially in group settings, you can get that real world practice with others who have similar goals. Supported education and employment. This is where individuals who receive these services can get help with communicating with schools and jobs to get appropriate supports. Or maybe a supported education employment specialist can help clients work toward different educational and vocational goals. And then last in this little bubble, peer and family support. You may have the opportunity to work with someone with lived experience who either has their own history of receiving treatment for psychosis, and they can walk alongside clients in their recovery process. Or you may work with a family advocate, for instance, who is a family member of someone with psychosis or supports other family members of their clients. Best practices also indicate supporting families in other ways. Some clinics offer multifamily group as one way for ongoing learning among and between family members. And this is often in a closed group setting so that you can continue to kind of build rapport within that group. And then there's also these psychoeducation workshops like we're doing today, and that will also continue with our How to Stay Well psychoed series. And then one other area is you can sometimes, a good focus for families can be family-focused therapy. And this can be a space for families to learn more about psychosis, work on interactions, communication, and problem solving that can work toward alleviating factors that are maybe disrupting the family system. So as you're thinking about all these different treatment options that are offered in this coordinated specialty care setting, it's important to understand what it means for something to be evidence-based. So for a practice or treatment to be evidence-based, it means that it's backed by high quality, well-controlled, rigorous research experiments. In addition, it takes into account clinical expertise in the person that's delivering that treatment, as well as patient values and preferences. And it's really important to remember that treatment is not one size fits all. You should be working with your clinical team to always tailor and individualize treatment approaches based on all these factors, really wanting to make this the most effective treatment for you. And so just lastly, a small plug, not going to go too much in detail, but you may have heard things about like dietary supplements or vitamins or special diets that some people say help psychosis. We want to caution you that that is not an evidence-based treatment. There's very limited evidence to support the use of vitamins and supplements to treat psychosis. But as we reviewed before, there are some things that are protective factors, like we talked about having a healthy, balanced diet, limiting processed foods, getting good sleep and all that. With that said, it's very important that you tell your treatment team and your prescriber about any vitamins or supplements that you or your loved ones may be taking. So there can sometimes be interactions with medication or unknown side effects, and we want to just help you proceed as thoughtfully and as possible with your treatment. So as we've gone through today, you've learned a lot about what is psychosis, what causes psychosis, and how do we treat psychosis.
This may be obvious, but these are two different workshops, the How to Stay Well and the Psychosis 101. We don't recommend that you do them at the same time, even though we're doing them at the same time now. It's a lot. For our sake, we will jump in. Some things to consider. In our clinics here, we have these occur monthly and we alternate. So 1 month we do Psychosis 101, and the next month we do the How to Stay Well, and we kind of flip back and forth so that people could go to each, and there's enough time to get new families into the clinic for each of them by the next one. Occasionally we'll mix something else in, but things to consider for your clinic, right? How frequently do these occur, so that you have enough people in there to generate good questions and build a little bit of cohesion. We typically think about this as the second one, the How to Stay Well, with Psychosis 101 as a prerequisite, right? Starting with the general psychoed. I would plan for at least an hour and a half for this. You will see that much of the work here is iterative. There's some talking and discussion together, and then people do a little bit of work on their own. For the sake of time today, we're going to skip the work on your own time just to move us through. That does make it take a little longer. Okay. For this workshop, much more than the Psychosis 101, there's a community is important. The conversations that are happening in the workshop are pretty key. We'll try those today. So I'm hoping that you will consider some group participation if you're up for it. There are a couple reasons for this. The main goal of this How to Stay Well workshop is to develop a wellness plan. Your clients who are there will develop a wellness plan. Their family members will develop their own wellness plans. This normalizes also, right? The child gets to see their parent do the same thing. The child and the parent get to hear what each other does to stay well, what each other's kind of triggers are. So within a family, that's valuable. And then also from one family to another family, hearing what other families do, getting suggestions from other people for what they do is really valuable. that the meat of this is the wellness plan and are those discussions, much less you conveying information, although there is some of that. And I think it's really valuable as a clinician for you to participate here too. You share your own wellness strategies, your own triggers and signs of becoming unwell. It normalizes and it kind of reinforces the spectrum idea again. We're all in this, we all operate similarly. This isn't us focusing on you as sort of the problem, right? Or the person who needs the help or support. So really key here, okay? You will see that as we go, you are going to provide people with a copy of the wellness plan at the beginning as they walk in. If it's over Zoom, you'll need to have an electronic version. And the idea is that they may be completing bits of this as you go. So as suggestions come up, as you say things, as other families say things, where people are like, oh, I do that too. Write it down, put it on your plan. So you can encourage people to kind of write right as they go along. This is like healthy modeling by you as a valued healthcare provider, by the parent as a parent, other families as maybe you feel alike to those other families. And this is much more conversational. You may even, if you're doing this in person, think about how you set up the chairs. This is a really nice one for like a circle where everybody can kind of see everybody else. It might be, you might consider that differently than you do for the Psychosis 1-on-1.
Yeah, I just want to reiterate again, as we're stepping into our presenter hats, we might say we're going to pause the video here, but we have like placeholder slides that will help to facilitate some of this along. And then I was just going to say, if we are asking folks to, follow along, please go to the link tree and download that the document that says long wellness plan. So let me pull that up. This one right here says long relapse prevention wellness plan. And so you can add, you can personalize this for your own clinic and for yourself. And then you'll be able to kind of go along. So if you want to open this up and work on it as we go, please, we really, really encourage you to do that.
Yes, not just lip service. When I do this, I do my own wellness plan, and it actually is helpful each time, even if you're just remembering your strategies or writing down. So yes, please do this along with us. We're going to say pause at the points where you might stop for like 5 minutes. So first question, and you will see as you follow along that wellness plan really mirrors the order of these slides. So you would invite your families to have some discussion here, as we will with you. So what does it mean to be well? What would we look for if we see somebody and say that person's well, right? What would tip you off? Okay, so mood, happy, engaged, present. Okay, able to focus. An impending sense of dread sounds very clearly not a clear indicator of feeling well. Okay.
Having the capacity to help others. So your bucket runneth over, so you can share that at that moment. I like that. Aware of your emotions, right? You can do that check-in with yourself. You're not just going through the motions of the day.
One key point of this slide is that there are many aspects of ourselves and our lives that we look to, that we can consider feeling well or a bit unwell. So you may want to point this out to your families as you go through this. We are talking about physical health. We're talking about social health, mental health. Yeah. These are all connected. So, Jem, I think you're kind of making the same point at the same time. Yeah.
I would say for me, being able to sleep through the night, that's always a good one. And we know when our sleep is off kilter, a lot of those stressors can come up, as we talked about before.
Yeah. For me, being able to be present, focused, and not stuck in my head or critical. Yes, those are key signs for me. I think the goal here is to generate a bit of thinking and really help people reflect that being well mentally is a much broader than just symptoms, right? We are really trying to get people to generate that concept on their own. For this wellness plan, there are really 4 key components, 4 areas at least that we're going to focus on. These are the 4. We'll go through them in turn, starting with proactive, preemptive wellness. There are kind of 2 different ways to work on your wellness. One is the things you do every day because you know they keep you well. So that's where we will start. Second is warning signs. Your ability to notice that you might be starting to feel a bit unwell. Third then is triggers. So if you've noticed you've started to become unwell, you need to know what the things are that tend to push you there, right? Knowing yourself, I think, is key. These are all part of the preemptive coping. And then the last is the sort of reactive coping. So once you've noticed that you have started to show some of these signs, what are some things that you can do to reduce signs of feeling unwell and push you back into your area of wellness? So both preemptive, knowing your warning signs, and some of these reactive strategies. So wellness plans are important. Most people don't make these, right? Most people, you may know yourself, most people don't have this written out. It's particularly important for those who are seeking help and support at a clinic and for their family members for a couple of reasons. It really helps you cope ahead, right? It helps you build in a routine and a daily life that incorporates some of the things that might prevent these signs of unwellness from popping up. It can help you plan, right? Knowing where you've been and knowing what's helped you in the past can really help you plan for when something does show up. What have I done in the past? What could I do now? Yeah, and it helps to prepare you. I will say it is also really useful for family members, because for any of us, in the moments when we're already feeling unwell, this stuff is harder for us to access mentally, right? When you're in it, it's harder for you to express what you need and ask your loved ones to do things to help you. So if your loved ones already know this stuff, they can kind of jump in, right? You can have these conversations beforehand. When I'm feeling unwell and you ask me, are you okay? Are you okay? Right? That's actually stressful for me. Knowing that ahead of time, just as an example, that's a common family dynamic, right? Those are some of the reasons these are important. Thinking again about this model, we plan ahead to reduce the likelihood that we hit that line. So we talked to you about our various treatment approaches before. So our goal is to bring people from right to left, bring people right. If you know what your stressors are, can help to bring you from top to bottom. If you know what keeps you well physically, right, you can kind of move people from right to left. Okay. Just to orient you to your handout, I think we've maybe done a pretty good job of this. You will want to do this with your families in the room. Show them around, let them see all 4 parts of the wellness plan. If you have one, you can kind of flip through it just so they know the territory that's going to be covered. We'll be using this worksheet. You want to make sure everybody has one. They have something to write with. If you're doing this on Zoom, perhaps even more important, make sure that somebody has a way to fill this out. So if you don't ask, they might just sit there and not be able to access this.
And I just want to add that this is adapted from the Connections and Care Symptom Management and Relapse Awareness Guide to Relapse Prevention. So I just want to give credit there that we've adapted this.
We packaged it sort of differently, but we did not make this. Yeah, thank you. So the first section is things you do, that preemptive coping, things you do to stay well. So let's throw this to the group. What are some of the things you all do or we do maybe every day, maybe frequently, because we know in the long term, it keeps us well.
Develop healthy habits, drink lots of water, good sleep, structured bedtimes.
I think we want to emphasize to our families that these are different for everybody. Knowing yourself is key. Regular exercise.
Yes.
I know for me, actually, as an extrovert, like if I'm in my house for too long, that's no good. So having some outlets to like be around other people is a key part of wellness for me personally.
I'm opposite. I need a little recharge time alone after a lot of socializing. So too much of that might push me over the edge, right? Too much of the socializing.
If you have time, it's nice to see some family dynamics here. And maybe you can get, child, parent, or client and loved one to notice some things about each other, share some things in common. It's a really good opportunity. We're sharing some after we've gone through this. Hopefully you've encouraged everybody in your group who feels comfortable to share something. You may want to pull some people in. We're not going to do that today. So once you've had a few minutes to discuss, this is a good time to pause. So you might say, okay, great. Got great suggestions. We're going to take a couple of minutes. Go ahead and pull out your wellness plan and write down all of those great suggestions that you've come up with. As you're sitting there, if people finish early, you can also maybe encourage within the family units to take a peek at each other's or make some suggestions. Honey, you do this other thing. You seem to really like it. Put that on there.
I don't know if you saw on the previous slide too, attending therapy sessions regularly, that can be a part of, I know when I go to those regularly, that's helpful for me.
And that's a good suggestion too in the workshop. Now that you've had a few minutes to write things down, let's share. So it's kind of like two opportunities. Let's share what you came up with. Anybody have things they wanted to add? And again, I think this is a really nice opportunity to catalyze some within and across family interactions. So people are learning about each other.
One, I was going to say, getting a good snuggle in with my cat. You already met her tail.
Talk to a friend. Yeah. Okay. Venting. Right.
And this is very different across different people. Encourage that individuality here.
Good point. So some skills are good both as preemptive and reactive, like deep breathing. Having mindfulness practice, meditation, or just deep breathing on its own. I noticed that when I listen to great music, I always feel better afterwards. So building that into my life is key. Coming home to a tidy house, I like it. Feels good. So hopefully at this point in your workshop, you've had some good discussion.
Right. So we will move on to our next part of our wellness plan. So a critical step in creating your wellness plan is also recognizing signs you are starting to feel unwell, right? And so you may have recognized various symptoms, behaviors, or feelings that happened before you're feeling unwell. If you did not notice any of those things, maybe even others around you may have noticed. So that's where it can be very helpful to have family members here who are able to provide some of that context. And so whether you recognize it or whether others recognize it, these are called warning signs. And most noticeable, they can start, weeks before or months before a relapse. And here we're considering a relapse. We use this term to describe that return of symptoms after a period of being well. A really important part of this process is identifying your early warning signs or warning signs in general, that a relapse is coming. It also may be helpful to break your warning signs into different categories. So here we have some examples of early, middle, and late warning signs. So you are also aware of the order in which your warning signs have occurred. Before we jump into your own experiences though, let's think of something that's maybe a little bit more generalizable to everybody. Let's think about allergies. For instance, if we thought of someone who had an allergy to shellfish, what are some of the early, middle, and late signs that you're having an allergic reaction?
I might think an early sign is hot, flushed, maybe.
Itchy, yes. Yeah. Swelling, yes. And so, right, you may notice some things at first and they may worsen over time. So, right, for me, I thought scratchy throat, feeling hot, and then maybe building up on that middle, seeing hives, swelling, and then maybe towards that late warning sign, you may already be having trouble breathing, right? Think of some examples that might be applicable to many people that they'll easily kind of latch on to this idea, this concept. Shifting back to kind of your own experiences, what are some of the warning signs you notice in yourself?
Calling out.
Calling out from work. Got it.
I know for me, my brain gets stuck. That's like middle. Thought I get stuck on whatever it is.
Little rumination, negative thoughts, irritability, impulsive thoughts, low energy, an introvert withdrawing. Yeah. As a mental health provider, less patience and empathy, bored as an early sign. What about what make others around you notice too? Some of these are things that others can notice, but something like being bored, maybe other people don't notice that. What are some things that others might notice about you? Angry easily.
Yeah.
Quick fuse.
Less responsive to calls, texts.
And again, some of these, might fit at different points on that early, middle, late, and they could be different for different people too. You might have an earlier warning sign of one of these that other people don't. Early symptoms can sometimes look like negative symptoms. It can be hard to identify. As we talked about before, those mood and negative symptoms can sometimes have that little bit of that overlap. That can be hard to notice too.
Another good reason that we do this with loved ones or support people, right? Because you have a chance to notice things about the person you're there with. Giving a kid a chance to notice this about the parent, right? If that is okay for them and their family, it can be very normalizing also.
Just to walk through a little bit more of each of these different categories, some early warning signs may be things you may not be too distressed about are, noticeable and they get in the way. You have trouble concentrating. You feel nervous, difficulty sleeping. Maybe in that middle level, this might indicate you're becoming more distressed by things. So your coping strategies might be to avoid things or little things set you off in a big way. So this might be, not talking to friends, not attending school or work, feeling more irritable. We talked about a couple of those in your examples. And then maybe some late warning signs are things are getting pretty serious. Maybe you're isolating, staying in your room. We talked about, someone brought up being disheveled, so maybe not showering, taking care of your hygiene. Maybe more internal experience, feeling numb, like moving from that bored place all the way to feeling numb. And so the goal here is to better recognize these early warning signs so that you can put your wellness plan into motion quicker and getting support doing that. That's a big component here. I just want to share, you also have this handout in your resources. It's called Common Early Warning Signs Handout. And specifically, we've come up with some that may be more common in psychosis, but you can see that a lot of these are applicable to many people. So like that normalcy, that validating your experiences, that this is a pretty common. And so we hope that this maybe can start to generate some ideas for you if you're having a tough time identifying your own. And so if you want to take out your worksheet, you can start to fill out these different categories for you. What are some of your early warning signs, middle stage, as well as late warning signs?
Right, in a workshop, we might pause here for a couple of minutes. We might encourage people to work silently first and then check in with their loved ones. Whatever feels right.
And then we would come back together and say, let's share. Starting to recognize some earlier ones: tired, trouble focusing, middle, irritable, annoyed. Yeah, those little things are getting to you. For you, the late is the avoidance bit. Okay. Yeah.
I think it can be useful to share with people here sometimes this concept again, that like the earlier you go, the less your signs look like the things that happen to you. And for all of us, we're all vulnerable to something, right? This is very normalizing. We're all vulnerable to something. So, as stressors build, whatever we're vulnerable to is likely to come out. It's this like process. For parents, it might be frustration, anger, anxiety. It's have to be psychosis.
Yeah.
I know a lot of my late ones are very anxiety focused. Much.
I'm an avoider. Yeah. I can relate to that one.
And as a leader of this workshop, if you can share too, I think that's very helpful.
Again, normalizing these experiences.
For my middle, I can be a catastrophizer or a glass half emptier. People notice that. So like worry and critical bits.
Definitely a slow, I think in the middle, slower to respond to friends, maybe takes a week. Again, this is an ongoing process. So even if you don't think of things right now, you can always go back and edit them, add things. So next up, as we had heard earlier, it's important for us to anticipate situations or stressors that may cause you to start to feel unwell. And this we think of as triggers. So thinking about our analogy earlier, outside of the shellfish example, what are some other things that people are allergic to, or could be a good analogy here? Like we said, the flu earlier.
So what might a trigger be in diabetes?
Too much sugar.
Something that sets off the issue. Yeah.
We have some other ideas of flowers and trees, like the springtime is an allergy that you notice. And so your triggers are maybe specific types of pollens, right?
Particular foods.
Yeah, I got a couple food allergies. I understand. Along with the diabetes, maybe you already have diabetes, but a trigger for it to worsen or come back is running out of medication or not taking your medication as prescribed. What do you experience when you have an allergic reaction? And then does this impact what you do in your behaviors? I've been thinking about the shellfish analogy. Maybe in your early warning signs, for getting hot and having itchy throat might mean it's time to take a Benadryl. So that might be like, okay, we can stop this before it gets too bad, kind of situation. Versus I'm at the I can't breathe stage, so I need my EpiPen. Different types of interventions at different points, depending on how intense the trigger was too. We're talking about triggers, and these can be the things that lead to warning signs and symptoms. So those things that are impacting you more significantly, depending on what's going on. And so we can think of triggers as the things that set things in motion, leading to a relapse or seeing our symptoms worsen if we don't intervene. And so we have some different situations or events can sometimes be triggers. So, right, what are some example situations that you could imagine that might be triggers for you? And Dr. Shapiro, if you want to jump in.
Yeah, I think for this section, so we've set the stage with an example, like an allergy example. And so now our next goal is to say, what are some of your triggers? What tend to trigger those early warning signs for you? So these can be situations or events, mental states.
Mhm.
Those are good things to encourage people to start writing in their section here.
So again, for me, maybe as a little bit more of an introvert, being in too many social situations in a short period of time, right? That might be one of my triggers.
Social stressors are big ones for me. A fight with a loved one or family or friend, that's a key trigger. A deadline is a trigger for me. I know I'm more likely to show my signs of unwellness or symptoms. Just like in the other two sections, I think we want to generate some discussion first, then encourage people to work a bit on their own, and then loop back around together.
Lots of situations from poor sleep, some social situations, boundaries being pushed. So maybe too many things at work going on and having to saying yes too much, maybe.
This is another good place to encourage some family interaction. Also be careful, right? Because sometimes that doesn't feel good. If a parent's like, I noticed that this triggers you, right? But so you use some good clinical judgment, but yeah, key place for observations. You can see the logical progression here, right? The things you do preemptively to stay well, the signs. Now we're having people really identify what their specific triggers are. Knowing that helps you when you're walking into those scenarios. Know that there is some likelihood, there's some risk of feeling unwell in these scenarios. You can prepare.
This is also another, moment to remember we can't avoid all situations and triggers. So that's where learning different ways to cope comes into play. And, we'll talk about that next too, just as a preview. There's some that maybe you feel comfortable sharing in that group space. Well, you might keep some of them to yourself. But again, if you are having that experience, maybe there's someone else who's having that experience, and that can build some of that connection and normalizing, even while being vulnerable. So I know we're in a professional setting, and so it's a little bit different. So, but just wanting to let you know that can be a growth edge for some families.
Yeah, the hope is that if you hear somebody else say the thing and it applies to you, maybe that makes it easier for you to own it for yourself and label it too.
And again, maybe you keep this as a ongoing document, and when you notice different things, you can add to it, because often, sometimes it's hard to retrospectively recall some of these experiences. And so if you remember in the moment, you can add to it and have a record and can build off of that in the future.
We would give people a couple of minutes to work on this. As you've maybe worked on this while we've been chatting, anybody have any to add, right? We may want to pull people back and ask them to share. So by this point, right, we've got a wellness plan with our first 3 sections written out. We've had some nice dialogue within families, between families. And now we get to that, we talked about preemptive coping. Now we're talking about reactive coping. So this is the last section. You've now noticed some signs of being unwell. You've hopefully been able to label them as early in that flow as possible, but not necessarily. So the question then is, what do you do? And this is always kind of a complicated part of the workshop, because people are probably in different phases of developing coping skills, different stages of understanding, right? What makes them work. People have come to the clinic because they want some help with this part. So I think it is helpful to start by kind of giving that bit of education, right? That there are things we can do when we're feeling distress, with the idea of reducing that distress. Anything that works for you is great. You got to test them out to know if they work. Usually there's some experimentation, but we can start to think about that by looking at a few different classes of coping skills. That reactive coping, sign of unwell has popped up, you apply a thing in the hope that now that sign of being unwell is going to go away. So these are things like self-soothing skills. There are some examples on this sheet. Maybe you've considered them. If not, maybe you want to talk to your clinician about them. Sensory soothing is nice here. You can use your senses to distract or soothe. A warm bath, something that's pleasing to smell, as appropriate, a treat. Distraction skills are really key ones, really key, particularly with psychosis. Things that you can engage in that occupy your attention. We know as providers that our mental resources are finite. So when you are focused on what's distressing you, if you can focus on what's something else, you kind of overload the system, right? You move those finite resources elsewhere. Depending on how you're doing on time, you could get some suggestions from people. What are some distraction things that work for you? What are some good self-soothers that work for you? We don't have time today, so you can also kind of run through the categories and then get some suggestions. So good DBT skill is this opposite action. Concept here is often our responses to distress maintain that distress. Avoidance is a really good example. So opposite, if you know that about yourself, opposite action is a nice skill. Do the opposite of what your impulse is. If your impulse is to withdraw and curl up, go for a walk. If your impulse is to be really critical, do something accepting or find something funny or cheerful. Okay. Inducing some positive emotion is a key one. Mindfulness, these can be useful strategies, ways to focus yourself in this moment. Try some grounding skills or guided meditation. Focus on your senses to ground yourself. So if you have less time, the idea would be to open it up to the group. So let's do that. What are some reactive coping strategies that you all use that bring your distress down in the moment?
Something bad happened, like engrossing myself in a good TV show that will keep my attention.
Distraction, music, laughter. Laughter is surprisingly effective. Having somebody to talk to, venting. A walk, yes, moving your body. A walk is also a good way to change your setting. Distress has popped up when you're in one place. A walk helps you perhaps remove some of those triggers. Cell phone games, distraction, journaling, time. We would pause this for 5 minutes or so. Again, people to write down their own stuff, maybe families to check in with each other and give some suggestions.
Different situations might call for different coping skills. Absolutely. So if you have a specific wellness plan that's about maybe specific sets of triggers, having one flow for that, maybe you create more than one wellness plan, right? That has some different focus.
The last section, and this, a good safety plan is probably developed one-on-one or family with a provider. However, right, we may have people in our workshop who haven't done that yet, or may not do that. Sometimes people engage for a brief period of time. So we do want to get to this last piece. So if you're following along, right, preemptive coping, we know our warning signs, we know our triggers, warning signs have bubbled up, you try a coping skill. What if those have not worked and things continue to escalate? So the last part of this wellness plan is the crisis safety plan piece. So we want to encourage people, this probably more within families, in case symptoms come back and these don't work, who can I call on? My own strategies have not been effective. I now need to pull in some outside strategies. So usually the first step is there a safe, comfortable place I can withdraw to, right? Sometimes you do need to leave school. right? You get overwhelmed or work. Sometimes you may need to go and have your room, be able to spend a little time by yourself. If that's not working, the next step is, can you pull somebody else in? You call your parent. Can you call your best friend? So you may want to encourage, you would want to stop and encourage people to write these things down here, right? What are the next steps? And what can they do? What would you like your loved one, your support person, your friend, your coach, your pastor, rabbi, right? Your whoever is on there. What, now that you're feeling pretty good, what would you want them to say to you when they're not? Maybe it's like, let's go for a walk together. Maybe it's you want them to remind you of something. Okay. And then the last step is your emergency plan. Right? If we're really in an emergency here, where do you want to go? Who are your doctors that you're going to call in a pinch? They're not there. What are the emergency contacts? And we're happy to share our plan. You should have a plan with the appropriate contact numbers. So you should edit this so that it has the right crisis call lines, the right local, if you have an after hours crisis service at your clinic or institution, put that on here. And again, this is probably best done with an individual clinician. It's not really the focus of this staying well, but we want to present this idea and at least have a bare bones just in case. And I think you can probably say that to the family. This is really something developed within your family or with your providers. So we want to encourage you to do that as the next step. It's not right. Just again, not really the focus of this, but we want to mention it.